If you are an experienced coder, or if you are just starting out, have I got a treat for you. Hello, my name is John Lin. I'm a urologist in Gilbert, Arizona, also your humble host of the Thriving Urology Practice Facebook group, where we crowdsource practice management solutions to benefit everybody. I recently came across while surfing on the internet and listening to watching YouTube videos, I came across a very interesting individual. She calls herself Bleu, Bleu. That's actually her name, and she calls herself a fashionista and a geek. She is super involved with coding and in a facility and also an outpatient setting. She on her YouTube channel she talks about coding, billing, how to become a coder, and the headaches and dealing with providers and she not only is she's not stuck in one position or one specialty. She gets moved around a lot because of where she works. So I am super excited that she agreed to let me interview her to share her knowledge and wisdom with everyone on the Thriving Urology Facebook group. So thank you so much for doing this, Bleu.
Hello.
All right. First of all, to give everybody some context, you started this coding thing in 2007, and you are a self-professed fashionista and a coding geek. Your favorite, which is probably the most confusing part of coding, is E&M, evaluation and management.
That's right. Yes.
Okay, can you tell us where you work in a system where you are placed in different specialties?
Mhm.
In which specialty are you working right now?
Orthopedics primarily and podiatry.
And you are working in the outpatient clinic capacity, is that correct?
Yes. Hmm.
Okay, tell us a little bit about your day-to-day.
Well, I work a lot with outpatient encounters. So basically, when a patient comes in for a clinic visit, I'll just take a look at the documentation and see what's going on. Sometimes they have minor procedures done in the clinic, and other times they'll be sent for surgery. Of course, we have to have a ear
So,
pop out. Okay.
that's okay. So you are dealing with not just E&M, but also possibly modifier 25 events, modifier 57 events.
Yes, yes. A lot of E&M and procedures done in the same day. Yes.
Okay,
Yeah.
sounds interesting. And what I have never heard before from a coder is that you actually read the New England Journal of Medicine on the regular.
Yes, I do. I actually subscribe to them now. I hadn't for a while because I was just didn't really think that I could, and then I started looking into it, and then I got signed up on the website, and they give you access to a few free articles a month. And so I was like, oh, well, I may as well just go ahead and sign up for the membership. So now I subscribe to them and I get their journals very regularly. And it's very fascinating because they have so many interesting articles done by these providers, and then you get to see them in their more like relaxed state and like they're talking to their peers. And so I just sort of get to like listen in when I'm reading these articles. So that's why I like it.
So on your YouTube channel, you talk about a lot of challenges when you deal with your providers and you get moved around. So now you've been in ortho and podiatry for a little while. So tell us, what typically do you do when you are moved into a new position and now you have to deal with new providers whom you haven't trained?
Well, I always make myself available. Like I always go and meet them right away. I That's the first thing that I do. Anytime I get a new assignment, my first stop is the clinic, and I will bring a little goodie bag of just like bottled water and maybe some candy or something. Because how can you be upset at somebody bringing you candy and water? So and it's just a good way to say hello and break the ice, and because that normally does not happen, and usually they hear about a new coder, you know, just making an offhand comment, oh, you have a new coder. But for me, I like to go and actually physically meet the new provider to me. And I'll tell them, well, if you have any questions and, let me know. That's what I do because I want them to be comfortable speaking to me, because a lot of times they think that they know, but maybe they're missing out. And that's the whole point. I don't want them to miss out ever if I can help it.
So breaking the ice with something sweet and just introducing themselves. So physically, I know in large institutions, the providers are in clinic, and then
Mhm.
the coders are somewhere else. And just so that everyone knows, you abstract from the documentation. Is that correct?
Yes. Hmm.
Okay, so your coders are not your providers are not putting in the ICD-10 nor the CPTs when they perform stuff.
Sometimes they do, and sometimes they don't. So it all
Okay,
depends. Sometimes we get to just sort of check it and make sure that it's okay. And then other times we have to add or take away or correct a diagnosis that was selected.
got it. So in my practice, I actually provide the ICD-10s and I include the CPTs as well
Oh,
as the
good.
modifiers, whether that goes on the E&M or the CPT. For
Good.
all the procedures that we do in the office. So literally, my biller, all she has to do is make sure I've applied the correct modifiers, make sure that I captured everything that we did, and then she
Yes.
simply submits the claim after the claim the scrubbing the
Hmm.
first pass scrubbing goes through. You also do not do any billing. You strictly
No.
do coding.
Yes, just the coding. I
Okay.
there we have a separate department that takes care of that.
Okay.
So they're the ones that handle all the insurance companies and things like that. So I'm very fortunate that all my function is just the coding. So I get to do, for me, it's the fun part, which is the
Because
coding.
you are I mean it's clear in your on your YouTube videos you are clearly passionate about helping other coders on
Yes.
their journey, whether that they're thinking about becoming a coder or possibly in bettering themselves. And some of the coders in the field are actually struggling because they don't have your drive, they don't have your personality to really want to meet your providers and educate your providers. Really, that I mean that's what you're doing, because
Well,
once you get there, go
yeah, and
ahead.
sometimes they're scared, and sometimes they don't know if they can. I mean, I went through that myself, and it took one person to say, "Hey, no, I want to meet my coder," and like I didn't always know that that was a possibility. And another thing that's so bad about certain coders is when they're going through their training program, they go through these rapid programs that are just so quick, and they just, you'll learn when you're out in the field, but they don't really train them on just the basic stuff. I mean, like learning how to look up an answer, just a basic flow of how that goes. So that's what's unfortunate, because sometimes they get out in the real world and it's just like sink or swim. And I feel bad for these coders because they shouldn't have to go through that. They should be better trained.
Just because you know something doesn't mean you understand how to apply that knowledge.
Yes, exactly. Exactly.
When you are physically separated from the clinic,
Mhm.
how do you communicate? And you mentioned in one of your videos before that communication with your providers is just absolutely essential.
Yes, I mean, it is. You have to. What I do, because I'm so far separated from some of them, I will physically go walk over to their side of the hospital. So, that's what I mean. I just have to make the time, and sometimes I'll go over there on a break. You know.
Now, do
So.
you batch a bunch of questions that you have for a certain provider before you go over across the pond and see them at the other side of the hospital?
Sometimes I do, and sometimes if it's just maybe one or two that's really pressing, something that really needs to have attention priority, I will go over there, because sometimes they don't want to answer email, and that's an issue because they get so many emails, and
Yes, we all get spammed.
so you can't blame them for not looking at their email right away. And so with some providers it's like they want email and others just don't, so then that's when you have to learn as a coder to tailor your treatment of providers to what they prefer and what is better for them.
It sounds like you tailor your communication style to the way the provider wants to communicate with you.
Yes, yes, I do. And
Well,
sometimes I have to kind of go against what they want and just sort of do things my way so that they can know, because sometimes they don't know that what they need is what I can provide for them.
what is really dangerous is that we don't know what we don't know.
Exactly.
And
Exactly. And
until someone like you, who has the vested interest of the providers,
mhm.
comes across and then tells them gosh, I hope your providers, physicians, and APPs really listen to you, because I have not met many coders who take such interest in her job and also in such willingness to communicate and teach the providers, so they are literally doubling and tripling their productivity.
Yes, and I've seen it, and it's the day that I did see it for one particular neurologist, and she had went from having a coder that did not talk to her at all to me, and I was just like, "Well, you're missing this, and you're missing this, and what about this?" And she got very upset with me, but I worked with her and I stayed with her through that time of just like she was just fighting me. She
She's just
had
floundering.
Yes, and she was just like, "I just don't understand, like, why are you doing this?" I said, "Because I want what's best for you." And then months later, after she stopped fighting me and after we, were able to come to a common ground, she did thank me. She said, "My productivity is tripled, and I can't thank you enough. It's because of you." And so I was just like,
Wait, wait,
"Oh."
wait, 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 wait. Let's make sure that we drive this home to the listening audience.
Uh-huh.
You helped a neurologist triple her productivity
Mhm.
from correct coding.
Yes, yes, because she wasn't selecting her
Wow.
correct procedures and she wasn't documenting appropriately to meet the levels like she should have. And she would have evaluation and management levels that topped out at 99212. And
Are
she
you
should
kidding
have,
me?
yes.
Oh my
And so
gosh.
she should have gotten a 215. And I would tell her, you got to work with your templates. You got to work on these things because I can't give you what's there. But I spent all this time. I said, okay, but where is it in your documentation?
So you are
So,
literally teaching these providers E&M coding.
yes. Or what is most appropriate for what they're providing. Because sometimes like they try to, oh, maybe if I do this and it's a level 5. No, not every patient's going to be a level 5. You're going to have some patients that are going to be level 3 or level 4. But with these patients that are higher in complexity, of course, you're going to have to make sure that all of your documentation is there so that you can meet that level 5.
And that is so true. So my question is, I was listening to your YouTube videos and your interaction with your providers.
Mhm.
How are your providers being taught E&M coding besides coming from you?
Nothing. They say that they get briefly taught in medical school,
No,
or that
maybe
they get,
recently, but not when I was going to medical school.
yeah, or they say that they get like they do the the association meetings, like
Yes, in
the
their
American
specialty
Academy.
meetings.
Yes, they get some of those, and then sometimes the last physician assistant that went to hers, she showed me what they were talking about. I said, okay, this is okay, this is all right, because I always, any kind of training they get outside of me, I need to review because I um I need to know that what they're telling you is in line with what I with what I'm saying. So yes, they have to rely on their association meetings a lot of times for that. And then a lot of times it's just it's like an elective. They don't have to take these. So it's up to the provider.
I have been a huge advocate of coding and billing training, and I've been attending my specialty society's coding and training courses and practice management courses for over 10 years. I
That's
am a huge
wonderful.
I'm a huge believer, so much so that I now speak in one of the training courses.
Oh,
So
good.
so I'm a huge believer in training, and I don't know how to get the message across to some providers that they are leaving so much money on the table, especially
Oh,
for urology. We are highly procedure oriented,
yes.
and being missing out on those charges, you're just, I mean, I just breaks my heart.
Oh, what is really heartbreaking is when they say, "Oh, it'll even itself out in the end." No, 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 no. It doesn't need to even itself out. You need to get paid for what you're doing. And a lot of times when providers don't want to listen to a coder, when there's a we call them physician champions at my
Yes.
facility. And
Yes.
so when they have a physician champion, somebody like yourself that is involved and knows, it does help. So to bridge that gap of, well, somebody else take care of it. And another misconception that some providers have is, oh, the coders will take care of it. No, we can only code based on what you have. We can't just make up whatever we want, regardless if we may want to, but we can't.
100%.
Yeah, we can't just make up what's not there. So this is why I tell them, your coder is not going to code for you. Well, I'm not meant to be a coder. I understand, but I need you to give me your documentation. I need you to tell me what's going on because I'm not in the room with you.
As you said in one of your videos, if it ain't documented, it hasn't been done. And that is actually literally what Medicare says in their 95,
Yes.
97 E&M manual.
Mm-hmm.
So a lot of
Yes.
the problem is that I see is that there are these rules,
Mm-hmm.
and then we just want to see patients.
Right.
So to reconcile the two, that is difficult. But the doctors and APPs who understand what's needed for
Mm-hmm.
you to do your job so that we can maximize and correctly document and maximize revenue,
Mm-hmm.
you have to understand at least a little bit of the rules.
Yes, yes. And I do listen to another physician, and he has a funny, Facebook and everything. Uh, I don't know if I could say who he is.
Oh, yeah, of course, yeah.
Z Dog MD. He
Oh,
talks a
yeah.
lot. He talks so much about physician burnout and that they just want to see patients and they want to be healers and they want to take care of their patients. And it's so hard when they have to be shackled in these administrative chains, basically, of, well, you're not documenting this, you're not documenting that. This is why I'm a strong advocate of using templates, because you can't always think of everything all the time. I mean, you're taking care of patients, that's your job. And so this is why I tell all the coders any coder that I come across, of you need to make sure that you show your provider that you want to partner with them and they can trust you, because that's the only way they're going to be able to really effectively do what they do. And so it's our job to help them with the documentation part and understanding why it's so important.
I just wish there's a magic wand that I can wave so that everyone will understand the importance of the synergy and the collaboration between the coder and the physician. Now
Yes.
I'm in a unique position in that I provide the service, I code, and I am aware of the billing aspect of
Hmm.
of the entire revenue cycle.
Yes.
So you are in a unique situation in that you don't have to deal with the billing aspect. But in yet another one of your videos, I watched a lot of your videos in preparation for this interview. In another one of your videos, you were present when a rep was trying to introduce a new technology to an orthopod, and it was
Yes. The
it was
Mako.
robotic or some sort of computer enhanced, and
Hmm.
tell us what happened there.
Oh, so with the Mako, using the Mako machine, it's a device that assists with joint replacement for orthopedics. It's so incredibly fascinating. I was very excited when it came to our facility, but they did not have the correct CPT code. And whenever they were describing it, they kept saying it's a robot, it's a robot. Well, of course it's a robot. But when in terms of how a medical coder would look at it, it was not coming up under robot. And I tried and I was trying to get this code and it was not popping up, because like the code that did come up in the encoder was just not, it just didn't look right, and I could tell there was something wrong with it. So I looked on the web, and sure enough, I was able to find the correct code because it said computer assisted, and I was like, well, but it's just a matter of how it's being described as well. So a lot of times these reps don't necessarily know what procedure codes, they just know about the product. So, and that's kind of bad if you don't know what CPT or HCPCS code goes for this particular procedure or
Well,
device.
well, a good rep will be just absolutely circumspect. from
Yeah.
they would consider the entire revenue cycle from how the
Yes.
patient presents, and then how the procedure is done, what the back office staff needs to do, and then what CPTs and HCPCS that are needed, and
Hmm.
which ones, and in what order, and can you include that with an E&M or not with an E&M, and what modifier you may use. I mean, a good sales rep or a good company, actually, an
Hmm.
empathetic med device company, would provide
Hmm.
all that information so that the provider and you would
Hmm.
not be suffering on the back end. And for
Believe it or
so
not, it's rare though. It's rare to find a rep for anything that is that detailed. And they think, oh, it's not their job, it's somebody else's job. And sure, I mean, the coder can find it, but if they are not as willing to look for things, or if they're not as detailed, then they're not going to pick the correct procedure code.
Well, I know a lot of urology practices, and actually a lot of the med device reps who cater to urologists. They
Mhm.
are absolutely sharp. These medical device companies will not just introduce the technology, the benefits, etc., but also give you all the codes that are necessary, and the
Wow,
the
that is
globals
awesome.
and the globals and everything. So maybe that is somehow getting lost after your providers start to use it. Maybe if they can give you the rep's contact information, maybe you can reach out, as a suggestion. You can reach out to them and say, hey, what are
Yeah.
the CPT codes that are possible when someone uses a newer technology?
Yeah, that would be good. That would be good. And sometimes we're waiting on actual
Op
procedure
report.
code, right?
Oh,
Because sometimes they'll be in a category
category three.
that's, yes, that's not quite ready. I always say those category 3 codes are waiting to be asked to the prom, because they don't have an actual, procedure code yet. PRP is really good for that because PRP is at 0203T or something like that. I just thought of that at the top of my head.
Are your providers doing a lot of platelet rich plasma injections?
Yes, they are. They are, because it does help with instant relief, sometimes for pain on some patients. So,
Interesting.
yes, but there's no CPT code for it. It's just a
Nope.
category 3.
So how are the well, I guess you don't do the billing aspect. So
Well,
how
they get no money for that. There's no
oh so
money in
they
that.
so they know they don't get paid.
Yes, they do
how
know.
how can the hospital sustain, or the healthcare system in which you work, how can they sustain a potential loss like that?
Sometimes there is, it's just going to be an understood part of it. Other times, if there's something else with the patient that's going on, then that's when you can get an evaluation in management if they are seeing the patient for a separate condition as well.
Sure.
Sometimes they'll make the decision to do the PRP in the same visit, and they'll say, well, it's going to take about an hour. Well, I also have this other issue. So then they do get an evaluation in management out of that. But sometimes it'll be just that they know they're going to lose on that particular encounter. I mean,
Yikes. So they lose out on the well, I guess it's not covered, so I guess there's no RVUs associated with it, right? So the
oh well.
provider that gets zero professional, and I wonder if the healthcare system gets is it the hospital multi-specialty clinic? I wonder if they get paid, because you have to collect it from somewhere, right?
Right, but sometimes when you have to hit those ones that are just zero RVU, and that's about the extent of that I know about it. So
Wow.
it's like, yeah, and when they found out they got nothing for PRP, they
Uh
got
huh.
mad, and they said,
Uh
"Well,
huh.
what about the blood draw? What about this?" I said, nope, 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 because I would show them in the book all these other procedures. You
Bundled.
cannot code these, yes, and it's bundled, and you can't put them together, and so
Speaking
yeah,
speaking of bundling, I'm not familiar with Encoder. It sounds like it's a piece of software that you can do
yes.
research and figure out what. Does that thing have the ability where you can put in multiple CPT codes, and then it will tell you which one you should bill first, and then which one requires modifier when you put it all together?
Yes, it does. It gives you a suggested, it's through 3M, and it does give you a suggested modifier list. Okay, whatever is appropriate for that particular procedure code. It will list the RVUs in order. it won't put them in order. It won't put the procedures in order for you, but it will tell you which procedure is RVU rich, and then so on and so forth. So then you can, put them in order as needed.
Okay, I have something for you that will automatically put everything in the order that you should code it, or you should submit it for claim, putting the highest RVUs first, and it'll tell you which codes can be built together. And if you put in multiple, you can it'll rank it all for you, and it'll tell you which modifiers are applicable for this two combination of codes.
Wow.
It's called it's called the bundling matrix, and it's through the
Oh,
it's through Coding Today. I'll put the link in the video description.
yeah,
So
definitely. I gotta check that out.
it's amazing for coders. It's
Yeah.
amazing for coders. Yeah,
Yeah,
we
that's
we
awesome because the people on my channel are always asking about that.
oh so get your institution to subscribe to it. It's I mean
Mhm,
for the amount of time that you save to be
mhm.
able to code a procedure or an office visit when you have, especially if you're doing mostly outpatient, right? So
Right.
for inpatient facility stuff, I think, or actually OR stuff, I guess, because you are in a facility.
Yes, yes.
I'm in a non-facility, but for the OR stuff that you may use and you may code for and submit and build multiple CPTs,
Mhm.
using the bundling matrix will save you so much time.
Well, it sounds like it. That sounds really amazing.
Okay, what is interesting, when I listen and on different forums and on practice management forums through MGMA and stuff like that, people are
Mhm.
always asking about productivity for a coder. Can you
Okay.
speak, yeah, a little bit about that? What is your productivity? What is the expected productivity for a coder, etc.?
Okay. It can range. It's funny that you brought this up because I just did a video
Because I
about
watched
this.
it.
Okay. So it can range anywhere from 12 to 22 per hour, but it's going to depend, or encounters per hour. So, and this is for outpatient. I mean, inpatient is something completely different, but for the outpatient side, between 12 and 22 per hour. And usually the higher the productivity request is because the clinic is a lot more simpler and it's a lot more straightforward, and you have a lot of the same diagnosis with the same procedures going all the time for the multiple patients. But because I'm in a specialty facility, I'm in a specialty clinic, I get to do 12 per hour. So it's very important, at least to me, to always make sure that I get as much done as I possibly can in a day. The amount of encounters I get in a day, sometimes it will range from 110 to 150. And that's just the volume of encounters that I get. Now that I'm in more concentrated in with orthopedics and podiatry, that number is going to be a little bit lower, but my productivity is still going to stay the same. Now, it depends on what's going on with the provider. Sometimes they have very complicated patients and they need to spend a little more time. So that's going to mean that I have to spend more time looking at their stuff, especially if they're not selecting their own procedures and diagnosis codes, or if they're not doing it properly. And this is when I have to go after them and say, we talked about this, what's going on? And I don't generally get after my providers for maybe one or two. But if it is a high volume and they're just looking like they're just trying to get through, I will go and find out what's going on because there's usually something happening in those situations. But with productivity, I'm not always able to meet my quota every day. It's 90 per day. I sometimes I can't meet it. Most times I can, and most times I do exceed it because I am I am very on with what I do, and I do have a lot of people come to me every single day. It's not just providers; it's other coders as well, and so I do take the time to spend with them to help them to understand something, and I never send anybody away because it takes a lot to ask for help sometimes. And when you're asking for help, the worst thing you can do is have somebody say, I'm too busy for you, so I can always pick up my productivity later. But when you have somebody that's dedicated, like I am with what I do, then it's not an issue. Productivity is not an issue because I always
You catch
exceed
up.
what I do. Yeah, I
Yeah.
catch up. But like I said, when it comes to making sure that the providers are okay or other coders are okay, that's where my priority is. So
So as I was watching that video, and I thought to myself, gosh, if you have someone who is not as diligent as you, and a provider who is not good with supplying all the information that you need to code to the highest level possible for that complexity or visit, I wonder if the lazy coder would simply pick a safe code and bill it out.
yeah, and bill what's there.
Yeah.
Exactly. Yeah, and I've known many people that were like that, and it's very hard because especially when you have somebody like me that I look at each provider, and even though I've some providers I've never worked with, I know their work ethic. You can tell what their work ethic is. And so you just sometimes you have to like take a step back and you're like, oh, stay in your lane, stay in your lane. But yeah, that's why I always say you never know. I tell providers you never know who your coder is going to be. This is why it's so important to make sure that you are always documenting like you're supposed to, because then you're covered. So.
Yeah, 100%. Doris in the comments mentioned that she loves to see physicians who are embracing coding guidelines, better understanding for correct documentation and coding, and better reimbursement. And she's like,
Yes.
like this.
Yes.
She also, yeah,
That is really awesome.
she also said that agree they give us code CPTs and average reimbursement for devices they are selling. This is in regards to the device reps, but must be checked to verify if they are actually reimbursed in your region, and more importantly, by your payers.
Yes, yes. Because some payers are so, and I talked about this the other day when it came to modifier 58 alone, just doing the research on modifier 58, I found that in certain states, it's different for payers. And then it varies by payer by payer. So it's just like,
If the provider is not communicating with the coder and also the biller, how can he ensure? How can he even survive? I don't even I don't even get it. I guess in a large system where you make it up on the facility fees and stuff like that, they may not care as much. However, for the provider who is interested, it actually involves, so most of the providers, or some of them, they're paid a base salary plus production.
yes,
That production is actually measured, as you know, in RVUs.
yes.
If they are not capturing that, or if they don't have an astute coder capturing all the RVUs, they're going to never meet their productivity requirements.
Right. And then they get privileges taken away, like, their ability to do moonlighting or maybe taking leave whenever they want to. So that does impact them. I did have a run-in with a provider who was very upset. He didn't understand why he wasn't meeting certain levels. I said, sir, your documentation is just not there. And he's like, well, I document more than anybody else in this clinic. And no, not really.
So what do you say
But
to that provider?
when that did happen, I calmly told him, this is why we need to work together, because I don't know what's going on in the room with you, and the only way I know is through your documentation here. Well, he essentially said he was better than everybody else. I said everybody else went through the same thing that you're going.
Uh-oh. Can you hear me?
Are you there?
Oh, we're good.
Okay.
I don't know what happened.
I don't know. It was just like, it just said it was muted. I was like, okay, what's going on here? So anyway, going back to what I said. But I did tell him that, I can only help you if you let me help you. I can't do much more than that. If you don't want me to assist you, I won't. I mean, it's that simple. And
that is so, sorry to interrupt, but that is so typical of a physician, because we are so, to get to where we are, to get into medical school, to get through medical school, get through residency, and now orthopedics, you feel like you know everything, but coding is a totally different animal.
Yes, and he's subspecialty. So
Oh my
that's
gosh.
even more fellowship trained. Oh yes.
So now for you to tell him that you're doing something wrong, it's probably hard for him to swallow.
Yes, and but we did sort it out, and I told him, I said, "Sir, I said, if you would like me to stop, if you want me to code with whatever is there, and you don't get the maximum full credit that you can, I said, just let me know, and I'll stop. I will stop right now." And I think that sort of turned on a light with like, oh, she's really serious now. So he goes, "Well, I'm sorry, I yelled, and I shouldn't have yelled at you, and
Oh, good for him.
I'm angry, and I took it out on you." I said, "Okay."
Yeah, good for him for apologizing. That's what he
Yeah,
should have done. Because
yeah.
he so for a lot of physicians, they probably have never encountered someone like you with your work ethic, with how you are so dedicated and involved in trying to help them improve.
Mhm. Yes. And I hear that a lot.
Yeah, because I bet not many. I mean, new coder shows up in a coding office. They're not going over to the clinic to meet the providers.
Yes. Yeah. And sometimes they just don't want to put in that much effort. They're here to collect a check and go home. And
Yes,
it is
yes,
not. You see, even if they have this attitude of I'm here to collect a check and go home, what happens one day if your providers are not documenting fully and getting full credit, and all of a sudden the revenue's not coming in? And guess who's going to be cut loose? The coder. So for all of your, oh, I'm just going to collect a check and go home, you should have been concentrating on that, because now this facility is not, bringing in revenue like it should.
yeah.
That provider is losing credit and not getting paid like he should. So it goes all the way around. This is why I always tell people, don't have that attitude, because if you do, you're going to end up hurting yourself.
You never know how it's going to impact you. And also, when you are doing a job, you always want to do better than what they expect, so that
Yes.
you can ask for things, ask for that raise or ask for that longer leave, and you
Right.
can say, hey, you know what, I've been working my butt off, and
Yeah.
can I move up in rank, or you have the ammo to ask for the things that you deserve.
Yes. Exactly. Exactly. And nobody can mess with you, especially if you're doing a good job and you're going above and beyond. That's what I say. Even when there's no money for bonuses, oh, they don't pay me for doing anything extra, so I don't get bonuses or whatever. You should always, always continue to try to do better. And you never know, your facility may end up with bonus money. And I was surprised when my facility did have bonus money. So I was like, oh, okay. But I would have done it anyway, you know.
Speaking of bonus monies, I know pay for coders varies by region, and you can certainly look that up online. We don't need to talk about the actual numbers, but I am curious about bonuses now that you mention it. How does that happen frequently? Do you guys get any other incentive plans for abstracting faster, better, more accurately? How does that work? Because I have no idea.
Okay, so bonuses typically for other facilities, they get them some get them every quarter, some get them every year. We just happen to not have the funding the last few years to be able to give us. At least that's what they told us.
Yeah, sure.
But it does go on your productivity and your accuracy. And if you are meeting, exceedingly well on your accuracy and your productivity, then that is when you are going to be in line for a bonus. And I happen to do way more things last year. And so thankfully, it just happened to marry up with the time when they did have money. And so that's why I was able to get a bonus from that. But it is a percentage of your base pay, which is what they tell us. And then sometimes it's just a cash bonus of whatever they deem is necessary to give you.
So if you slack off
Mhm.
that year when they happen to have the money, you won't get that bonus
You won't
that
get
they
that.
have.
Right.
See,
Right. Because
that's
we get sort of evaluated twice a year. We get a midpoint evaluation to see how we're doing, and then we get a year at the end of the year. They want to know overall how did we do, and so that's when we have to. We either did really good or we did bad. So that's where they look at those numbers, and they look at how consistent the coder is, and they look at what else is going on. If they did get sent to a new clinic, or if they got sent somewhere else,
Right, right,
that gets considered as well.
right. All right, I don't want to take up too much of your time. One suggestion for you to give to provider and one suggestion for you to give to a coder. Shoot.
Providers, listen to your coder. Ask them questions. So ask them
Yes.
questions.
Yes.
And if they don't sound like they know what they're doing, ask another coder or ask their supervisor. Okay. You've got to get everybody involved. Okay. And for coders, study, study, study. And don't just, if a provider barks at you, that's okay. Just turn around the next day and go right back and just don't take it personally. They're under a lot of pressure. So that's my advice.
Well, wonderful. And for more about medical coding with Bleu, you can find her on YouTube. I will link up her YouTube channel in the video description. Thank you so much, Bleu, for doing this for us.
Thank you, Dr. Lin. I really appreciate the offer, and this has been so much fun.
Great. Bye, everyone.
Bye-bye.